Yes, I am here. I'm thinking. Uh, Mom has only hypertension, not diabetes. Okay, sorry. Okay, it's intrauterine growth, fetal growth restriction. One thought on that. Okay, so it is asymmetric, isn't it? Second or third trimester. Why? Head is 33 centimeter, 13 inch. Uh, uter Okay, it's asymmetric. So this patient has fetal growth restriction, which is defined as estimated fetal weight. Estimated fetal weight. His weight is 2.3 kg. So third percentile. Okay, but with less than third percentile. Okay. This patient has fetal growth restriction, which is defined as estimated fetal weight less than 10 percentile or a birth weight less than third percentile for gestational age. Fetal growth restriction occurs from a variety of etiologies, including maternal, placental, or fetal factors. Maternal factors Maternal factors include malnutrition, hyperemesis gravidarum, substance use, and conditions leading to vasculopathies, preeclampsia, pregestational diabetes. Fetal conditions include chromosomal aneuploidy and congenital infections. Most cases of fetal growth restriction as a result of uteroplacental insufficiency, blood flow, which is impaired blood flow to the fetus with subsequent decreased oxygen and nutrient delivery. Fetuses adapt to hypoxic nutrient depleted in utero environmental environment by shunting uh, blood from non-vital organs, liver, subcutaneous fat to preserve blood flow to vital organs, that is brain, which can lead to the following complications at birth. Polycythemia, induces increased erythropoietin and red blood cell expansion. Hypoglycemia, chronic nutrient deprivation results in lower plasma glucose and insulin concentration, leading to decreased liver and muscle glycogen stores. Hypothermia, shunting blood to vital organs, causes a decrease in subcutaneous fat and increased heat losses. Hypocalcemia, placental dysfunction, decreases calcium transfer to the fetus, and perinatal asphyxia and meconium aspiration. Growth restricted infants have a Growth restricted infants have a difficult respiratory transition following birth and may experience hypoxic events leading to organ damage. Placental dysfunction can cause intrauterine stress during labor and increase the likelihood of meconium stained fluid. Okay. Okay, so it's not Potter sequence because problem in the X-ray reveals multiple limb fracture. So multiple limb fracture usually not Potter sequence. Okay, type 2 osteogenesis imperfecta. An intrauterine fetal demise associated with growth restriction, multiple limb fracture, and intrauterine fetal demise, growth restriction, multiple limb fracture, and a hypoplastic thoracic cavity is consistent with type 2 osteogenesis imperfecta. Type 2 osteogenesis imperfecta. Type 2 osteogenesis imperfecta is an autosomal dominant disorder due to defective type 1 collagen synthesis that results in decrease that results in decreased bone density and increase skeletal fragility. This disorder has a varying spectrum of severity from mild type 1, moderate type 3 to type 9, uh, to fatal perinatal type 2 disease. Type 2 osteogenesis imperfecta is typically diagnosed via antenatal ultrasound, findings of multiple fracture, shortened femur, and a hypoplastic thoracic cage and growth restriction. Type 2 osteogenesis imperfecta is lethal. In utero Most fetus either die in utero during delivery due to trauma or shortly after delivery due to pulmonary hypoplasia, a complication of thoracic cavity hypoplasia. Infants who survive delivery are given supportive care. Yes, yes. Amniotic band sequence is associated with limb defect, amputation, hand defect, clubfoot, craniofacial defect, and or abdominal wall defect. It does not present with bone fracture and is typically not lethal. And Potter sequence is a lethal fetal anomalies that presents with pulmonary hypoplasia, limb deformities, clubfoot, hip dislocation, and oligohydramnios. The sequence is most commonly due to urinary tract abnormality, bilateral renal agenesis, polycystic kidney disease. There is no association with limb fracture. Bleeding is not that much. For vaginal Bleeding is not that much. Like for vaginal delivery, more than 500 ml bleeding is needed to cause PPH. So estimated blood loss is 300. Everything is normal. Fever, there is slight fever. And episodes of rigor. The plus. I think normal. Yes, because of chills and it can happen after fever. Even after surgery, there may be fever, like due to shivering. Okay. The immediate postpartum period and hours to days is markedly physiological changes that begin immediately after delivery. Okay. The postpartum period, the immediate postpartum period, hours to days. Immediate postpartum period, hours to days, is marked by physiologic change that begin immediately after placental delivery. Increase oxytocin level, endogenous and administered, causing uterine contraction, which compresses placental blood bed vessels and protects against PPH. As the uterus involutes, it rapidly decreases in size, becoming firm and palpable 1 to 2 centimeter above below the umbilicus. Involution also generates subsequent lochia, which initially appears bloody with small clots and can continue for weeks. Increased prolactin level stimulate breast milk excretion and milk let down over the course of hours to days. Infant suckling further increases the maternal prolactin and oxytocin level. So prolactin level increase and there is decrease estrogen and progesterone level in the postpartum. It can cause chills and shivering. It can cause chills and shivering with subsequent mild hyperthermia, low-grade fever in the first 24 hours of the delivery. Decrease estrogen and progesterone. That's why there is shivering. This patient's postpartum course is normal shivering, firm contracted uterus, normal lochia, and therefore only routine postpartum care with management. Only routine postpartum care with pain management, perineal care, and lactation support is indicated. Okay. Yes. Looks like hemolysis, elevated liver enzyme, and there is low platelets. Yes, maybe. Obstructive jaundice, but in obstruction, their ALP should be higher. ALP is in the normal level, isn't it? May not be. Uh, it- this is help. Okay. This pregnant patient with hypertension, right upper quadrant pain, likely has preeclampsia with severe feature new onset hypertension, more than 20 weeks of gestation, with signs of end organ damage and or HELP syndrome, hemolysis, elevated liver enzyme, low platelet. This disorder likely this disorder likely represent a spectrum of disease causing maternal endothelial dysfunction, hypertension, vasospasm. HELP syndrome also causes platelet overactivation, thrombocytopenia, and microangiopathic hemolytic anemia, the anemia with elevated indirect bilirubin due to deposition of platelet fibrin microthrombi within the capillaries. The liver is commonly affected in HELP syndrome. Microthrombi deposition in the hepatic hepatic portal system results in decreased hepatic perfusion, liver ischemia, hepatocellular injury, nausea or vomiting, right upper quadrant pain, and elevated transaminase. The gradual distension of the hepatic glycan capsule causes the classic presentation of the worsening right upper quadrant pain without associated peritoneal sign. Severe cases may also severe cases may progress to liver necrosis and hemorrhage, resulting in subcapsular hematoma, blood pooling beneath the hepatic capsule. Yes, yes. Obstruction of the cystic duct cholelithiasis may cause right upper quadrant pain, elevated liver enzyme. However, patients typically have elevated conjugated bilirubin or direct or conjugated bilirubin. There is no association with thrombocytopenia or hypertension. Acute fatty liver of pregnancy and HELP syndrome share the same feature, including hypertension, right upper quadrant pain, and elevated transaminase level. In contrast to HELP syndrome, which causes indirect hepatocellular injury due to Indirect hepatocellular injury due to decreased liver function, due to decreased liver perfusion. Acute fatty liver of pregnancy causes fulminant liver failure due to complete fatty infiltration of the hepatocyte. Therefore, patients with acute fatty liver of pregnancy typically have jaundice, encephalopathy, coagulopathy, and profound hypoglycemia. And patients with a peptic ulcer perforation can have right upper quadrant pain. However, they are typically have peritoneal sign, abdominal rigidity, rebound, or guarding due to intraperitoneal spillage of caustic gastric acid. Okay. Sorry. There is a crackle, bilateral crackle. Is it pulmonary edema? Oh, okay. Okay, pathophysiology of pulmonary edema in preeclampsia or eclampsia. Increased generalized vasospasm, systemic hypertension, increased afterload increased afterload against which the heart is pumping, pressure, increased pulmonary capillary pressure, pulmonary edema, decreased albumin and decreased renal function and increased vascular permeability. These patients dyspnea, hypoxia, and bivascular crackles. These patients dyspnea, hypoxia, and bivascular crackles on examination are most likely due to acute pulmonary edema, a life-threatening complication of preeclampsia with severe feature. Patients with preeclampsia typically have generalized arterial vasospasm leading to increased systemic vascular resistance and high cardiac afterload. In response, the heart becomes hyperdynamic to attempt to overcome the systemic hypertension. These causes increased pulmonary capillary pressure, which drives fluid from capillaries into the interstitium. Preeclampsia with severe feature predisposes to acute pulmonary edema because it causes endothelial damage, leading to increased capillary permeability. These increased permeability promotes decreased serum albumin and decreased capillary oncotic pressure that enables heart spacing. that is peripheral pitting edema. In addition, normal diuresis is impeded due to decreased renal function. Management includes supplemental oxygen, fluid restriction, dietary medication. In severe cases, fluid restriction and diuretic medication are used with caution because patients have overall decreased plasma volume due to third spacing and aggressive management. Aggressive treatment may compromise placental perfusion and fetal well-being. I do not get the point. So what happened in here?
Oh,
Backing up. Okay. Atrium, then um, backflow. Yes. Okay. Okay. Isn't it hydrospitalists? Parvovirus B19 can cause hydrocephalus, isn't it? Uh, but how this parvovirus B19? How she got this hydrocephalus? Okay, I'm reading. I haven't got the source. I know that parvovirus B19 causes hydrocephalus, but how? Okay. This fetal demise is most likely due to non-immune hydrocephalus. Fetal hydros, a sequela of high output, a sequela of high output heart failure, characterized by excessive fluid accumulation in the interstitial spaces. The most common infectious etiology of hydrocephalus is maternal parvovirus B19 infection. Most adults with parvovirus B19 infection are asymptomatic. However, parvovirus B19 during pregnancy can have devastating fetal consequences due to viral cytotoxicity to fetal erythrocyte precursor with increasingly severe fetal anemia. The fetal heart tries to compensate for hypoxemia by increasing cardiac output. However, eventually it cannot compensate. However, it cannot compensate and high output heart failure develops. As with other causes of heart failure, fetus develop third spacing of the fluid resulting in ascites, tense fluid with abdomen and generalized skin edema and a subsequent filling. Other clinical features include pleural or pericardial effusion and placental edema. Fetuses with hydrocephalus are at high risk for fetal demise. This risk increases with infection acquired at earlier gestational age. Due to this risk, patients with hydrops undergo serious ultrasound and possible early delivery. Okay, yes. Uh, Fetal hydrops increase cardiac output demand, causing heart failure, and increase fluid movement into the interstitial spaces, third spacing. Clinical feature is pericardial effusion, pleural effusion, ascites, skin edema, placental edema, and polyhydramnios. Etiology: immune is Rh immunization, and non-immune is parvovirus B19, fetal aneuploidy, cardiovascular abnormality, and thalassemia. Okay, you read the marker, these two marker, like all the marker, like what are, okay. So what is your thought? Open neural tube has maternal serum alpha protein is high. Yes, I told you, if you read the whole stem, there is nothing in the stem. In here, high up, I told you to remember the high up. Down syndrome has high up, like in Downs, beta HCG and inhibin is up, and other like maternal serum alpha fetoprotein in trial is low. And in neural tube, or sorry, yes, high means H for HCG, I for inhibin. High, HIGH, high up, written in the U, where written in the first state. That's why high A beta HCG and I for inhibin. So HI is up, that means elevated. Inhibin is up, so looks like downs. And we know that maternal serum alpha fetoprotein is higher if there is any neural tube defect, or if there any abdominal wall defect, or if in these two type of defect maternal serum alpha fetoprotein is high and rest of the parameter is normal. And for trisomy 18, like election age, like Edwards syndrome, in Edwards syndrome everything is low but inhibin is normal. Okay, you want me to read the explanation? Okay, we can stop here. I think that there is nothing in the explanation. Yes. Okay, you want to see that like if you like you cut the call and then I don't cut the